Hi all, welcome back to the emergency medicine lecture series. In a previous video on mechanical ventilation, I have discussed about the basics of mechanical ventilation, the terminologies used in mechanical ventilation. The current video, I am going to discuss about physiological effects and the physiological goals of mechanical ventilation. I am Dr. S. Prakash Babu, Associate Professor of Emergency Medicine, Karpagya Vinayaka Institute of Medical Sciences Research Center, Maduranthakam, Changalpattu. Mechanical ventilation uses positive pressure to open the airways and also keep the alveoli in an open state. Positive pressure helps in better oxygenation by keeping the alveoli in open position and also distributing the gas evenly so that the VQ mismatch can be taken care of. But it is associated with multiple adverse effects, mostly due to the mechanics. Mechanical ventilation can affect nearly every organ in the body, but lungs are the most frequently affected organs. When a patient is on a spontaneous ventilation, breathing normally in the room air, the intrathoracic pressure is negative throughout the cycle. It won't cross the atmospheric pressure at any point in the respiratory cycle. Intrapleural pressure usually varies between -5 centimeters of water during exhalation, which is the least pressure, to -8 centimeters of water during inhalation, leading to expansion of the lungs and inflow of the gas into the lungs. The alveolar pressure fluctuates from +1 centimeters of water during exhalation to -1 centimeters of water during inhalation, making the alveoli open and the gas can flow into the alveoli. Decrease in intrapleural pressure during inhalation facilitates lung inflation and also increases the venous return. But in mechanical ventilation, the reverse happens. Usually you are giving or applying a positive pressure from outside. The mean intrathoracic pressure is always positive pressure. Intrathoracic pressure increases during inhalation and decreases during exhalation. Venous return is greatest during exhalation, quite opposite that of the spontaneously breathing patient. It may be decreased if expiratory time is too short or the mean alveolar pressure is too high. So what is this mean airway pressure? Mean airway pressure is nothing but average pressure applied to the airway during the ventilator cycle. It is related to both the amount and duration of the pressure applied. During the inspiratory phase, you measure the peak inspiratory pressure waveform, and the inspiratory time. And during the expiratory phase, there is positive end expiratory pressure, which is used to keep the alveoli in open state and splinting them in the open state, and respiratory rate are the determinants of the mean airway pressure. And you need to know something about shunting. There is usually a physiological shunt, whereas perfusion without ventilation and vice versa. Shunt is nothing but perfusion without ventilation. In anatomical shunt, there is actually the blood is passing from right side of the heart to the left side of the heart without passing through the lungs. So the unoxygenated blood is entering into the arterial circulation and diluting the oxygen concentration in the arterial circulation, leading to reduced oxygen carrying in the blood. Normal anatomical shunts include Thebesian veins, which directly open into the heart chambers. They are the draining channels for the cardiac muscle. And also the branchial circulation can act as a normal anatomical shunt. Positive pressure ventilation usually decreases the shunt and also increases the oxygenation. If positive pressure ventilation produces over distension of some lung units, this may result in redistribution of pulmonary blood flow to the unventilated regions, leading to a paradoxical hypoxemia when the patient is mechanically ventilated. So when the positive pressure applied is inappropriate, it can actually worsen the anatomic shunt. Other pulmonary effects include the dead space. The dead space volume is usually increased because the tube that extends from mouth to the meson and the circuit of the ventilator will act as a dead space which is not actually participating in the gaseous exchange. It increases the atelectasis. These atelectatic lung units will lead to a VQ mismatch leading to hypoxemia. It can also cause barotrauma, pulmonary interstitial emphysema, and pneumomediastinum, pneumopericardium, subcutaneous emphysema, and pneumothorax are the effects of barotrauma. And finally, there is ventilator-associated pneumonia, which is an infection related to the ventilation of the patient. The types of ventilator-induced lung injury include barotrauma, oxygen toxicity, volutrauma, atelectrauma, and biotrauma. Let's discuss them one by one. First, let us look at how the ventilator-induced lung injury occurs. Alveolar overdistension causes acute lung injury. Alveolar distension is determined by the difference between intra-alveolar pressure and the intrapleural pressure. The cyclical alveolar collapse during exhalation and reopening during subsequent inhalation can increase the damage. If the PEEP applied or the total plateau pressure that is applied to the lungs is more than required, is over distension and derecruitment increases the inflammation of the lungs, which is called the biotrauma. This biotrauma can lead to generation of inflammatory mediators, which may translocate into the pulmonary circulation, resulting in systemic inflammation. So let us look at how exactly these things happen. Over distension of the alveoli, eventually the alveolar wall ruptures that can lead to air in the bronchovascular sheath, which can lead to systemic air embolism or pulmonary interstitial emphysema. When it progresses, it can lead to pneumomediastinum. Pneumomediastinum can further lead to pneumothorax, pneumopericardium. It can lead to subcutaneous emphysema, pneumoretroperitoneum, and also pneumoperitoneum can result as a result of ventilator-induced lung injury. Coming to the oxygen toxicity, high concentration of inhaled oxygen result in the formation of oxygen free radicals. Free radicals can cause ultrastructural changes in the lungs similar to acute lung injury. Volunteers who are breathing 100% oxygen will develop inflammatory airway changes and bronchitis within 24 hours. So oxygen should be used very, very sparingly, just like how you use drugs based on their doses. Oxygen should also be used based on the targets that are required. Oxygen free radicals can induce or worsen multi-organ dysfunction syndrome. So be very, very careful to reduce the FiO2 whenever possible, as soon as possible. Next is the stress and strain. Primary determinants of lung injury are stress and strain. Stress is defined as internal counterforce per unit area that balances the external load in a structure or the pressure gradient across the structure. Strain is nothing but the deformation of the system as a result of external load or change in size or shape of the structure. Stress is the alveolar distending pressure, alveolar pressure minus the pleural pressure, and strain is nothing but the ratio of volume change. That is the tidal volume plus volume increase caused by the PEEP, positive and expiratory pressure, is called the strain. Coming to volutrauma, volutrauma refers to lung parenchymal damage caused by mechanical ventilation, which is similar to acute respiratory distress syndrome. It is manifested as an increase in the permeability of the alveolar capillary membrane, development of pulmonary edema, accumulation of neutrophils and proteins, disruption of surfactant production, and development of hyaline membranes, and a decrease in compliance of the respiratory system. Next is atelectrauma. Is nothing but repetitive recruitment and derecruitment, that is opening and closing of unstable lung units. The junction between an open and closed alveolus serves as a stress raiser. It has been estimated that more than 100 centimeters of water of stress is created when 30 centimeters water of alveolar descending pressure is applied adjacent to a collapsed alveolus. So this causes trauma. Next is biotrauma. Biotrauma is usually because of the over distending of due to increased tidal volume and repetitive opening and closing of unstable alveoli, which result in activation of inflammatory mediators within the lungs. These mediators increase edema formation. They also cause neutrophil migration, and there is relaxation of the vascular smooth muscle leading to stasis. Injurious ventilatory patterns increase the systemic inflammatory mediator response compared to a lung productive ventilation strategy. So whenever you are mechanically ventilating a patient, there is both biomechanical injury and biophysical injury. Biophysical injury and biomechanical injury, they're both related to each other. The biophysical injury, shear forces, over distension of the alveoli, cyclical stretch, that is opening and closing repeatedly, and increased intrathoracic pressure, all will lead to increased alveolar capillary permeability, decreased cardiac output, and decreased organ perfusion. The biomechanical part of the biotrauma, cytokines complement prostanoids, leukotrienes, repetitive oxygen species, and proteases are released. Bacterial translocation will be there. Neutrophils will reach the area to the distal organs. There is tissue injury secondary to inflammatory mediators of cells, impaired oxygen delivery, cyclical stretch that further aggravates the reaction, and there is bacterial translocation leading to bacteremia, which can lead to sepsis and multiple organ dysfunction syndrome. Hyperventilation and hypoventilation. Hyperventilation lowers PaCO2 and increases arterial pH. Respiratory alkalosis can cause hypokalemia, decreased ionomer calcium, and increased affinity of the hemoglobin for oxygen. So oxygen delivery is impaired even though there's enough oxygen bound to the hemoglobin. A modest elevation in PaCO2 may not be injurious, and a pH as low as 7.2 is very well tolerated by most patients. Coming to oxygen toxicity. Oxygen toxicity is related to FiO2 as well as the amount of time that the elevated FiO2 is breathed. FiO2 more than 0.6 should be avoided for more than 48 hours. The high PaO2 may produce an elevation in PaCO2 due to Haldane effect. High PaO2 can produce a retinopathy of prematurity in the neonates. Cardiac effects. Positive pressure ventilation can decrease cardiac output, resulting in hypotension and potential tissue hypoxia. Increase in intrathoracic pressure decreases venous return and right heart filling. Increase in pulmonary vascular resistance decreases left ventricular filling and cardiac output. Increase in right ventricular afterload can result in right ventricular hypertrophy with ventricular septal shift and compromise in the left ventricular function, leading to reduced perfusion. Renal effects include decreased urine output as a result of decreased CO, elevated ADH, and decreased ANP. There is fluid overload. Gastric effects, usually gastric distension, stress ulcer formation, and gastrointestinal bleed. Nutritional effects include respiratory muscle catabolism, which increases the risk of pneumonia and the pulmonary edema. Overfeeding increases metabolic rate and thus increases the required minute ventilation. Overfeeding with carbohydrates also increases the VCO2, further increasing the ventilation requirement. Neurological effects include increased intracranial pressure, and most patients will have delirium after tube removal. Neuromuscular effects, usually on prolonged ventilation, polyneuropathy and polymyopathy are the common manifestations, and there's a reduced portal blood flow also seen in mechanically ventilated patients. There are effects on sleep like delirium, patient ventilator asynchrony, and sedation induced ventilator dependence. Patient ventilator asynchrony is nothing but disproportionate triggering of the patient and disproportionate triggering by the machine. There's proved sensitivity. Autopeep can develop. Incorrect inspiratory flow and time setting will result. Inappropriate tidal volume will be delivered, and inappropriate mode can be cause for patient ventilator synchrony. Mechanical malfunctions during ventilation, accidental disconnection, leaks in the ventilator circuit, loss of electrical power, and loss of gas pressure. To avoid these complications, patients should be very closely monitored, and there should be a regular maintenance of the equipment and a power supply 24 hours should be ensured when patients, especially in the ICUs. So that finishes the first part. There is physiological effects of mechanical ventilation. Most of the effects are in the lungs, but literally any organ in the body can be affected. Now let us look at what are the physiological goals of mechanical ventilation. Physiological goals are nothing but whenever you are mechanically ventilating a patient, you are going to concentrate on achieving these goals, which can limit ventilator induced lung damage and ventilator induced complications. During mechanical ventilation, it may not be prudent to target normal blood gas values, irrespective of whatever tidal volume you are using, pressure that is applied, and FiO2 used. Inappropriate use of ventilator may cause lung injury, activate the inflammatory mediators, and potentially cause or extend multi-organ failure. Volume that is delivered and the descending pressures are the most important targets when you are aiming at a lung protective ventilation. The primary goals of mechanical ventilation include, as in any other emergency setting, you should not cause any additional injury, no further damage, and you should avoid ventilator-induced lung injury. It's a prime goal. You should minimize the lung stress and strain, maintain adequate gaseous exchange, maintain acid-base balance at a level appropriate for specific patient. Again, you are not going to target normalizing the acid-base values, accepting a bit of hypercapnia, a bit of hypoxemia, which are called permissive hypercapnia and permissive hypoxemia, where indicated are relevant. Ensure ventilator patient synchrony. That is the most important to avoid any adverse complications of mechanical ventilation. So your targets include a tidal volume of 4 to 8 ml per kg ideal body weight. Note here, it's not the actual body weight of the patient, but it's ideal body weight that you are going to check. You're going to check in the charts. You measure the patient length and arrive at an ideal body weight that for that particular height, and then in that ideal body weight, you're going to give 4 to 8 ml per kg. Alveolar descending pressures, especially the flat tube pressure, should be limited to 30 centimeters of water. Flat tube pressure is measured by applying 0.5 to 2 second end inspiratory breath hold. PEEP, whenever applied. In mild ARDS, you can keep a PEEP of 8 to 15 centimeters of water. Moderate to severe ARDS, you can aim at 10 to 20 centimeters of water. Again, the plateau pressure, there is alveolar descending pressure plus the PEEP applied should not be more than 30 centimeters of water. Coming to permissive hypercapnia is the deliberate limitation of ventilator support to avoid ventilator over distension, allowing pSO2 levels greater than normal. The physiological effects of permissive hypercapnia include shift of oxygen hemoglobin dissociation curve to the right, decreased alveolar PaO2, stimulation and depression of the cardiovascular system, central nervous system depression, increased ventilator drive, pulmonary vasoconstriction or pulmonary hypertension, systemic vasodilation, systemic hypotension can result, increased intracranial pressure will result because of increased PCO2. Patient can become anesthetized when PCO2 level is more than 200 millimeters of mercury. Decreased renal blood flow will ensue when PaCO2 is greater than 150 millimeters of mercury, and leakage of intracellular potassium will result when PaCO2 exceeds 150 millimeters of mercury. Up to PaCO2 of 150 millimeters of mercury, there will not be any discernible physiological changes. So you can allow up to 100 millimeters of mercury of PaCO2 when you are aiming at permissive hypercapnia. Cautious use of permissive hypercapnia is recommended only when the VT and P plateau targets have not been met and respiratory rate cannot be increased further. Allowable limit for permissive hypercapnia depends on each patient and is usually 60 to 90 millimeters of mercury. FiO2 targets. The lowest FiO2 that achieves the desired PaO2 should always be used. A high P plateau is generally a greater concern than high FiO2. FiO2 should be maintained at least equal to 0.6. Some chemotherapeutic agents are used like bleomycin. The effects of oxygen toxicity are exaggerated, so avoid these drugs. Gas exchange targets. Normal PaO2 is 80 to 100 millimeters of mercury. Again, it depends on the age of the patient. PaO2 for normal lungs, your target is greater than 80 millimeters of mercury. If the patient is having ARDS, 55 to 80 millimeters of mercury will suffice. If the patient is a known case of COPD, 50 to 65 millimeters of mercury will suffice. PaO2 values for a patient with normal lungs, 35 to 45 millimeters, that is normal PaCO2 levels. Patient is having a lung injury, your target is 60 to 90 millimeters of mercury. pH, if the patient is having a normal lungs, you should maintain a normal pH as far as possible. If there is a lung injury, you should maintain pH at least greater than 7.2. Coming to the patient ventilator synchrony. Asynchrony is nothing but lack of coordination between patient's respiratory center output and the response of the ventilator. It increases the oxygen consumption, carbon dioxide production, and hemodynamic instability, sedation requirement. It may contribute to ventilator-induced lung injury. Manifestations of asynchrony include missed triggering or auto triggering by the machine, double triggering. Patient would have triggered once, the machine will again trigger at a set point, so the respiratory rate is increased. Inability of the ventilator to meet the inspiratory flow demand of the patient, or failure of the ventilator to cycle to exhalation. Thank you. Don't forget to share and subscribe these videos for wider dissemination. Thank you once again.